SDMC would fit to take over session. Welcome, sir.
The next is about the gallbladder pathologies. Gallbladder, of course, the anatomy you know about it. The variations, anatomical variations are many. It's a cystic structure which retains bile and it concentrates bile. But anatomical structures can vary significantly. It has a lot of surgical importance. The location of the cystic duct can vary, and even the arteries.
Sir, not audible, sir.
Huh? Hello. Ah. Okay, gallbladder variations are quite common, and there could be multiple variations, and the variations may have a significance in the surgical approach because of the location of the cystic duct and the branches hepatic ducts. Variations could be many, and this has a importance from that point of view. Now, the functions of the gallbladder are, as we have told, it's about the concentration of the bile. Bile would be concentrated, and the cholesterol would be secreted to a great extent in the gallbladder, and that concentrated bile would be secreted into the duodenum, facilitating the digestion process, particularly the fat digestion process, and maintaining the pH. The pancreatic duct and the common bile duct, they merge together and form the sphincter of OD at the duodenum. That's where the secretion occurs. The gallbladder is better visible in ultrasound scanning. USG is a better tool to make out the location of the gallbladder and the condition of the gallbladder in terms of its wall and the current content like the fluid and the surroundings can be made out with the USG as such. The bile would be really concentrated significantly in the gallbladder, and the difference between the bile secreted by the liver and the gallbladder bile is in the liver, when it secretes around 97.5 grams per 100 ml of bile, it will be 92 grams per gl in the gallbladder bile. That's about 5 ml, 5 grams of water is reabsorbed. Bile salts are excreted concentrated significantly in the gallbladder. The bile salts present in the liver is 1.1 grams, whereas it is about 6 grams in the bile of the gallbladder. Bilirubin also is increased as such. Cholesterol, markedly, the cholesterol is enhanced in the gallbladder bile as such, and fatty acids also are absorbed, secreted. Electrolytes also are maintained in such a way, so it has a major role in playing that maintenance of the main cholesterol and bile salts. And the bile salts are actually salts of the cholic acid, and they are somewhat moderately soluble in water. Cholesterol, of course, is a fatty content as such, which you know, and the secretion of the cholesterol is quite important in maintenance of the status of the plasma as such. And the bile salts are not single one, there are many, and mainly they are the salts of cholic acid, and they could be of different salts as such. Now, the biological functions of the bile are, it's about the maintenance of the cholesterol homeostasis, and it also has a function of the maintenance of the fat concentration in the body, and it also helps in the digestion of the fat by formation of the micelles. The micelles are where there would be a hydrophilic end and a hydrophobic end to this, and the bile salts as such, and they would be keeping that fat molecule, which is primarily water soluble, keeping surrounding it and forming it as a structure which can behave like a water soluble substance, though within it's water insoluble. And this is how the fat is absorbed in the body, and the mechanism of the maintenance of the fat is necessary. Moreover, bile salts are necessary to maintain the osmotic pressure of the intestinal juices. The fat digestion is again by the emulsification and the micelle formation. I think these issues are well known issues. The bile salts, it interacts with the fat molecule, forms the micelles, and it helps in the lysis of the fat molecule and it gets adhered as such. Now, the other important aspect is the bile salts would be having a enterohepatic circulation. A good amount of the bile is reabsorbed from the intestines and it again reaches over to the liver, again it gets excreted. So the amount of the bile salt which is excreted in the feces is usually much lesser than the bile salts which are secreted from the intestines. Some amount of that, a smaller amount of the bile bile salt would be excreted through the kidneys. Like so, in the urine you will have a minute amount of the bile salts which otherwise is not highly seen, like it will be less than 0.5 milligram per 100 ml. But suppose if there is any abnormality where the bile is either, there could be two abnormalities rather, either the bile may not be secreted into the intestines and the bile may get retained in the biliary system as what we call as obstructive jaundice conditions. In that condition, the unconjugated bile salt would be retained in the plasma, whereas if there is a excess of the bile salt secreted in the intestines and then the amount of the soluble form of the bile salt would be present in the plasma, and that's how you make out the jaundice conditions. That more of that we will be coming to that when we discuss about the issue of jaundice as such. Now, enterohepatic circulation of the bile also has an importance in the disease conditions like obesity and liver diseases. Like in these conditions, the fat absorption can be abnormal, and that abnormal fat absorption can result in deposition of the fat in the liver, and the fatty changes in the liver could occur. Moreover, it also can result in the plasma concentration, higher concentration of the plasma, which can result in many other disease conditions. So, fat metabolism and the status of the fat in the body has a direct relationship with the bile as such. Now, that's about the basic issues which we have already discussed about. We'll directly come to the disease conditions, and among them the cholecystitis. That again, we will apply the same issue like the Shula, Gulma and Udara concepts in the different stages as such. Now, cholecystitis is an inflammatory pathology of the gallbladder where 90% are having calculus. The stone present in the gallbladder either could be a cause of the inflammation or it could be an effect of the inflammation. Acalculous cholecystitis could be seen around 10% of the patients, where the organisms may reach to the biliary system either through the plasma, either through the circulation from any other source, or from the gastrointestinal tract. There could be an ascending inflammation into the area, or even it could be rarely the inflammation from the liver can reach to the gallbladder. So, by any of these means, the gallbladder may get inflamed, and usually the incidence is more in the older age and female sex as such, and pregnancy. Certain ethnic groups like American Indians, Native American Indians, they have very high incidence. In India, the incidence of acalculous cholecystitis comparatively lesser compared to the other areas of the world, whereas calculous cholecystitis is more common. Obesity and rapid weight loss also can be one of the factors which triggers. Drugs like hormonal therapy in women also could be a triggering factor for the cholecystitis. Organisms which are involved could be Escherichia coli, Bacteria spragulis, Klebsiella, Enterococcus pseudomonas are well known, and it may present in two forms: acute cholecystitis and the chronic cholecystitis. Acute cholecystitis is characteristically presented with the pain in the epigastric area, which also can be radiating to the shoulder. Vomiting. Murphy's sign is one of the characteristic features. Murphy's sign is what we call as a respiratory cat sign. When you palpate the subcostal area and ask the patient to breathe in deep, there will be sudden cessation of the breathing due to the pain felt at the area. So it suggests of a inflammation of the peritoneum in the subcostal region, and it often is attributed to gallbladder inflammation. So acute cholecystitis is characteristically presented with the tenderness at the subcostal area on the right side with respiratory catch, and fever is also common. Peritonitis can be seen, which is extending even beyond the right hypochondriac area. Gallbladder may be palpable occasionally when the gallbladder is distended. Jaundice is not seen regularly, but very rarely a few of the acute cholecystitis patients may have a clinical jaundice. The other way, the presentation also could be chronic cholecystitis, where the gallbladder wall may become thickened and the bile secretion could be abnormal, and hence the patient may not have an acute pain, but it would be a chronic dull pain and flatulence, irregular appetite, a bloating, and intolerance for other fat substances could be seen. In the acute conditions, leukocytosis is often seen, like total leukocyte count would be higher. Alkaline phosphatase also is raised in about 25%. MLS has to be tested in all these patients to rule out pancreatitis, because there is always a close relationship between the acute cholecystitis and pancreatitis. A cholecystitis may result in pancreatitis, and vice versa. A pancreatitis also can result in cholecystitis, and hence MLS is one of the usual investigations done to rule out the involvement of the pancreas. Now, whether the patients of acalculous cholecystitis require imaging studies like ultrasonography or MRI or CT, of course, in the routine practice, every patient is subjected to the investigations, but as per the criteria, the general criteria, American College of Radiology is the criteria is ultrasonography is the preferred initial imaging test for the diagnosis of acute cholecystitis. Scintigraphy is the other preferred alternative. CT scan is a secondary imaging test that can identify complications of acute cholecystitis and extrabiliary disorders when ultrasonography has not yielded a clear diagnosis. So that this should be the right thing. Ultrasonography is always the most preferred investigation. CT has a very limited role to play in only when you are suspecting some complications which ultrasonography might not have revealed. Then MRI is has to be done with the IV gadolinium based contrast medium, is also a secondary choice for confirming the diagnosis of acute cholecystitis. The other way, scintigraphy is the other choice of investigation which could be done. MRI may be useful than CT scanning for radiation exposure in pregnant women. That's the issue. Now, the imaging studies, cholecystitis would be seen in the ultrasonography with the thickened gallbladder wall or the presence of the abnormal bile, and even there could be pericholecystitis. The important signs which can suggest about the outcome prognosis would be the thickness of the gallbladder, thickness of the gallbladder wall. Thickness of the gallbladder wall, if it is more than 8 millimeter, that would be suggesting of a more severe inflammation which may require a immediate surgical intervention. If there is a biliary sludge and the contents of the bile would be altered, there would be heterogenic bile contents, then also it could be one of the indications for the interventions. Presence of the stones, calculus cholecystitis, the total outcome would be different, and hence there again the approach would be different. If there is a pericholecystitis, presence of inflammatory fluid around the gallbladder wall, that also can be made out with the ultrasonography. So when you refer a patient for ultrasonography, the important features which you have to observe are the type of the content pattern of the bile fluid, the dimensions of the gallbladder as well as the gallbladder wall, and presence or absence of the inflammatory changes around. In the CT scan also it will be the similar issue, presence of that pericholecystitis can be better made out with the CT scan as such. Now, one of the important issue is some of the patients, or rather majority of the patients of cholecystitis also may have some ECG changes. It's due to the vagus nerve being connected to the sinoatrial node as well as the gallbladder, that There could be often in a good number of patients the ECG changes typical of a T wave inversion with maybe prominent T wave can be seen, which can result in suspicion of this ischemic heart disease often, and this has to be known. So ECG changes in cholecystitis is a very characteristic, which may be resembling that of a ischemic heart disease, but it is not ischemia. Once the gallbladder is removed, the things may become normal. So there again you need to have some discretion. Characteristically, the ST segment depression would not be more than 2 millimeters in cholecystitis induced ECG changes. T waves would be prominent. Spiked T waves are the characteristic feature there. Then the treatment in acalculous cholecystitis, usually a simple medical treatment would be enough, and the usual treatment would be the antibiotics, which of the antibiotics should be preferred would be those antibiotics which are secreted from the bile and gain sufficient concentration in the biliary juice. They have to be prepared, and those antibiotics which have a better penetration efficiency in the bile are piperacillin, tigecycline, amoxicillin, ciprofloxacin, ampicillin, and cefepime, levofloxacin are. Whereas those which have a lesser penetration capacity are ceftriaxone, cefotaxime, etc. And that's about the choice of the antibiotics which should be used, and those antibiotics which are not secreted by the biliary system would have lesser efficiency there. Then nasogastric suction if necessary, IV fluids to maintain the electrolyte balance. Now in those conditions where the gallbladder would be non-functioning, cholecystokinin also could be administered as a standard protocol of the treatment. One of the important things is analgesics may be indicated, but not the narcotic analgesics. Narcotic analgesics of opium derivatives petidine or petidine derivatives should not be given in cases of the gallbladder biliary system pathology, because they have a property of producing the spasm of sphincter of OD, and when there is a spasm of the sphincter of OD, the pressure in the biliary system could be enhanced remarkably, and in those conditions where already the gallbladder is inflamed, the biliary system is inflamed, it can result in a rupture. Now, as far as my usual clinical prescription would be, of course, Mrityunjaya, Arogyavardhini and Kumari as well. Antibiotics may be necessary if the patient has a very high glycocyte count, that's more than 17,000. As per the Indian antibiotic policy, the antibiotic policy of the ICMR, which is now our health ministry has accepted that antibiotic policy, and according to that, the biliary disorder, antibiotics used in the biliary disorder are the wide spectrum antibiotics like penicillin derivatives like piperacillin, tazobactam, ampicillin are the first one. Second generation antibiotics are ceftriaxone and ceftriaxone, that's the one. Third generation cefoperazone and sulbactam are the ones, and monobactams like azithromycin also is used. Fluoroquinolones like ciprofloxacin, levofloxacin are suggested. The interesting issue is, rather controversial issue is, many of them are low penetration efficiency drugs which are suggested in the Indian antibiotic policy. Metronidazole also is added to this combination when anaerobic bacteria are detected as such. That's the usual suggested treatment. Now, certain of the complications of acute cholecystitis can occur are, one is the empyema of the gallbladder. The whole gallbladder may become involved with the pus. There could be a rather huge enlarged gallbladder asset with pus inside, which is an acute surgical emergency, and in that condition the total leukocyte count would be very high, and the tenderness also would be extensive. There could be extensive area involved, not simply limited to the right hypochondrium. The area of inflammation of the peritoneum could be wider, and in that condition immediate surgery is necessary, or there could be a rupture, and rupture can result in widespread peritonitis. So empyema of the gallbladder is one of the complications. Whereas mucocele is another of the complications, where After the antibiotics administered, the pus may not be formed, but the sterile this bile may get retained in between the submucous and mucous area, and the whole gallbladder may become distended. The clinical signs in that condition would be like the patient may have lesser pain could be reduced, but the flatulence and the gastric vague appetite changes could be persisting, and there could be a palpable mass. The mucosal may become palpable, and ultrasonography can confirm that the presence of that sterile fluid can be confirmed, and that also is a surgical indication. Surgery is necessary in that condition. And the clinical signs of mucosal would be the acute inflammatory signs are very minimal, large, palpable, minimally tender gallbladder is found on clinical examination. Laboratory test results normal or just within upper limit of the reference range values. The biochemical test would be normal. Plain radiography may show a density over there, but ultrasonography shows evidence of thickening of the gallbladder wall, and often a stone in the neck also may be seen in such conditions. If at all you aspirate during surgery, there could be white bile seen over that, and that's how it is mucosal is seen, and that has to be operated upon. Another of the complications which can occur after the cholecystitis would be biliary sludge. Biliary sludge is that heterogeneous bile contents. The bile, instead of being clear, there could be some residual substances maintained over, and this also can result in a chronic cholecystitis, can progress into chronic cholecystitis. And in such conditions, ultrasonography shows about the thickening of the gallbladder wall, and that heterogeneous substances, many times the gallstones also, and the high density substances present in the bile can be made out. Though it is considered as a surgical indication in general, many of these patients can be managed with our Arogyavardhini and Kumari Asava much efficiently without any complications if the gallbladder wall thickening is not more than 8 mm. But if the gallbladder wall is more than 8 mm, it's better to go for surgery. So that's about one issue. The next issue is about the gallstones, the stones formed in the gallbladder. Now, whether these stones in the gallbladder have to be considered as Ashmari or otherwise is the issue of controversy. I would not consider this as an Ashmari because Sushruta might not have identified these stones, but Sushruta might have considered this as probably the Shula and the possible complications of the Udara later on. Whereas cholecystitis as such, a primary cholecystitis with acalculous cholecystitis is simply the Shula. Whereas gallstones could be the evidence of either a gulma or the udara, depending upon. That's how I suggested instead of going for a simple diagnosis of Ashmari, because Sushruta has considered Ashmari as the disease of the related to the Mutra Ashmari, and though the Pittaja Ashmari is mentioned, it's not related to abdomen, so that's the issue of controversy, debate. We will not go into that part much as such. Now, from the clinical point of view, gallstones have mainly 4 categories of the presentation. The one group of the patients who have a high risk of gallstones, and there may not be a visible gallstones, that's what we call the lithogenic state. Many of the patients may present with a risk of gallstone formation, and you need to handle that. Then another group of the patient would be presenting with a gallstone which is identified only when some investigations are done, but the patient may be asymptomatic. So that's about asymptomatic gallstones, which also are quite a huge number of patients who come with that symptoms. Then comes the symptomatic gallstones, where the patient may have repeated biliary colic. Then the patient may have complications like a rupture or gangrene and so on. So our approach to the treatment can be of different categories. The approach can be changed, it has to be changed according to the stage in which the patient presents in. So I would like to discuss these issues separately, lithogenic state, asymptomatic gallstones as such separately. Now, lithogenic states or lithogenicity is a tendency to form the stones would be decided by one with the genetic factors. Like certain of the people, some specific genes are identified and those who have that history of gallstones in the family, they may have a high intensity of these gallstone formation. Then there are certain factors related to the intestinal conditions. Food substances, certain typical food substances can be a cause for the gallstone formation. Those food substances which have more of fat, more of oily substances, they also have a high risk of developing the gallstones as such. Then patients who have hepatic hypersecretion, there could be increased secretion of the insoluble substances like either the pigments, bile pigments, or there could be increased secretion of the cholesterol that also can produce the gallstones. So those who have a tendency to have a increased pigments in the plasma or increased cholesterol, that's one category of the patients where we may categorize them as lithogenic patients. Or patients who have gallbladder hypomotility, the motility of the gallbladder is lesser. Physiologically, it occurs in pregnancy. In pregnancy, because the intra-abdominal pressure is increased, the gallbladder will be less movable. Moreover, hypomotility also can occur if the patient has undergone any abdominal surgery earlier, particularly vagotomy. Patients who have undergone vagotomy, they have a high risk of that the stone formation. Or the hypomotility also could occur in obesity-like conditions. Then there could be gallstones which can occur due to sudden changes in the physical conditions, like a patient who has bedridden for a long time, suddenly due to some acute phases, like, or some patients who have stroke, they tend to develop the chances of gallstones quite frequently because of the sudden changes in the physical condition. The stone formation, the theory of stone formation is based upon the relative concentration of the bile salts, cholesterol and phospholipids. The bile salts are the substances that keep these substances in a cholesterol and phospholipids in a liquefied form or dissolved form, whereas the cholesterol and phospholipids are the insoluble substances. A real stone formation is related to the interrelationship of the concentration of these. There is a very strong hypothesis now built up where if the concentration of the bile salts is more, the chances of the stone formation would be lesser. But at the same time, higher the concentration of the cholesterol, even if the bile salts are normal, there could be the concentration. See, when the bile salts are very high, the chances of the stone formation are lesser, even if the concentration of the cholesterol is very high. But if the concentration of the bile salts become lesser, then there could be a stone formation as such, and the incidence of the stone formation can be more. If the phospholipid concentration is also higher, then too the chances of the stone formation would be lesser, whereas if the phospholipid concentration becomes lesser, then the chances of the stone formation would be more. So those persons who have a relatively lesser bile salts and lesser phospholipids, they have a high risk of forming the stones. They have given 3 phases, whereas the other way is 2 phases. Those who have a higher concentration of the phospholipids and bile salts in the bile, they are given as a first phase as such, or chances are lesser. This is about the lithogenicity based upon the statistical analysis and presentation. The types of the stones are mainly 3 categories: cholesterol stones, mixed stones and pigment stones. Cholesterol stones are usually single in number and they are large in size, bigger in size, and when you look at the stones, they may be having yellowish color and the surface is smooth, and when you cut the stones, you may see layers of different fatty substances, and usually they would have a soapy consistency in the sense they are compressible, not very soft, hard, but when you press, the shape can be changed. Mixed gallstones, they are usually having multiple stones and they are very hard as such, and their surface would be sharp as such, hard, and surface would be sharp, and usually their color would be blackish because of the deposition of the substances, or at times it could be greenish also, greenish or blackish would be the color. Pigment gallstones are due to the blood pigment only, and they are characteristically very hard, and the surface would be hexagonal. Often the surface would be shape would be hexagonal, and they will be having lamellated appearance. The surface could be adherent to each other. And the contents of these stones would be like in a cholesterol stone, the cholesterol would be very high, whereas the calcium would be comparatively lower. Whereas in pigment stones, the cholesterol level would be comparatively lower, calcium would be very high, calcium and phosphate would be very high. That gives the consistency of the stones. As far as the incidence of the stones are concerned, in India, majority of the patients who have the stones are cholesterol stones are the majority of the conditions which we see in India as a type of the stones are the cholesterol stones. Now, the factors which protect the gallstone formation, which prevent the gallstone formation, as per the current this physiology would be, statins are considered to be beneficial in preventing the gallstones. Ascorbic acid also is known to prevent the gallstones, and unsaturated fats, and coffee is considered to be one of the substances which can reduce the incidence of the gallstones. Vegetable proteins and nuts also would be reducing the chances of the gallstones. These are the known factors. As far as the incidence of the gallstones are concerned, the incidence of the gallstones are very high in Northern America, and India comes at a zone where it is moderately high, somewhere in the middle. In some geographically, there are some areas where the stones are lesser. In India also, the stones are more in the northern part of the country than in southern part of the country. In our area, in Udupi district, the incidence of the gallstones is much lesser than what you see in the north as such. Now, as far as the causes of the gallstones are concerned, now we have now come over to the stone, asymptomatic or symptomatic, from the lithogenicity factors. Now, the issue is when a patient has a lithogenicity, high risk of the stone formation, the cause for the lithogenicity has to be assessed, and a suitable modification of lifestyle could be the suggestion as such. But once the stones are formed, the common causes which trigger the stone formation are obesity, pregnancy, gallbladder stasis, that's as I told you, all that hypomotility condition. Certain of the drugs like hormones, there could be heredity also. And there is a usual rule of usually described mnemonym of 5 F's, and those 5 F's are fair, more prevalent in the Caucasian population, fat patients where BMI is more than 30 kg per square meter, or patients who have hyperlipidemia, female patients, fertile where there is more than one or more children, and then 40s age. So a fertile female in 40s with the fat and fair appearance has a high chance of the stone formation. Now, as far as the clinical diagnosis, the clinical findings in the diagnosis of gallstones, the symptoms which are characteristic of the gallstone as a clinical presentation are patients who present with the biliary colic. It's one of the important acute colicky pain. Episodes of colicky pain is one of the most important clinical evidence by which you can make out the diagnosis. The specificity is about 94%. If the patients complain of an acute pain, episodes of the acute pain in the right hypochondrium repeatedly, that could be the most reliable clinical evidence of the gallstones. If there is a radiating pain towards the shoulder, that's another feature where the specificity comes to around 61%. Patients who have a habit of using analgesics repeatedly because of that episodes of the pain, that's around 51%. Fat intolerance is another of the reliable, is patients who are not able to tolerate the fat food substance, again is a more specific clinical evidence of the stones. Tenderness in the upper abdomen, accuracy is lesser, but still it's one of the important issue. Food intolerance and upper abdominal pain are major clinical symptoms of the gallstone which is formed. Confirmation of the gallstones can be better made out with the ultrasonography, where the morphology of the stone and the status of the gallbladder can be made out. Plain X-ray is of very minimal use, but it could be useful in calcium-containing stones. The pigment stones or mixed stones may be visible in the plain X-ray, or there could be a deposition of the calcium in the gallbladder and form a porcelain gallbladder, which also may be rarely seen. But choice of the investigation is always the ultrasonography, where all that variations in the gallbladder, number of the gallstones can be made out. CT is another of the alternative to make the diagnosis. Now, the tools by which it can be diagnosed as per the international standards would be ultrasonography has a high specificity of 98% and sensitivity of 95%, and hence it's always a choice of investigation. Then assessment of the hepatobiliary amino acid studies, biochemical studies, is another of the tool which is rarely done in the routine clinical practice, but from the your generalized guideline point of view, this also is one of the other choice of investigation where it's accurate by around 97%. MRI and cholangiopancreatography also are useful in certain of the conditions, and their sensitivity is around 97%, but and specificity also is 98%. CT is comparatively having a lesser sensitivity of 79%, and endoscopic retrograde cholangiopancreatography or ERCP is done only in specific conditions where you have to rule out the obstruction, where the biliary obstruction can, and the location of the biliary obstruction may be studied. So it's not done in routinely to make the diagnosis, but once you have a confirmed diagnosis of gallstones, and if there is a suspicion of biliary obstruction, ERCP is the other tool. Abdominal X-ray would be having a very little uses as such. Once the stone is formed, the possible complications can occur could be a good number of patients may remain asymptomatic. Usually around 45% of the total patients who have a gallstones, they may be remaining asymptomatic throughout the life. Only when the investigations are done, you may be seeing. The other complications which can occur are, the most common complications are episodes of biliary colic, or it also could trigger cholecystitis, or it can be a cause for mucocele, which we have already discussed in cholecystitis conditions, empyema, or a gallstone may result in a fistula, like rupture of the gallbladder and a biliary fistula could be formed, a perforation of the gallbladder. And another theory is a stone persisting for a long duration can result in metaplasia and can be a cause for the gallbladder carcinoma, but the incidence is related only to around 5 to 10%, but still it's a issue of controversial issue, and most of the times the recommendation for the cholecystectomy in asymptomatic patient is done with an idea of preventing the possible carcinoma. Mirizi syndrome, where the patient may have recurrent jaundice, or choledocholithiasis, where the stones may even form the common bile duct which can produce obstructive jaundice. Cholangitis, where inflammation of the biliary system within can occur. Stones also could be formed within the liver, which become quite difficult to manage. Pancreatitis could be one of the complications of the gallstones later on, or a gallstone which has migrated into the intestines may get enlarged and may produce a obstruction. Treatment guidelines, the standard medical treatment guidelines would be, it's not necessary that every patient needs to have a surgical intervention. Though in the routine clinical practice, usually once the stones are identified, patients are recommended for surgery. But the universal guidelines is not that a medical treatment of ursodeoxycholic acid of 900 milligram per day is usually recommended in the conditions where the patients have a normal gallbladder function, or there is no calcification and the stone size is smaller, like 0.5 to 1 centimeter. This is the usual guide. But what I would feel in my clinical experience, what I say is patients who have a smaller stone size, they have a high risk of developing a possible common bile obstruction which is unpredictable. A stone may float in and then it may result in a CBD obstruction. And the risks are more when the gallbladder is functioning normally, because the bile will be flowing. A non-functioning gallbladder otherwise will be asymptomatic, and that can be better managed. So that's the something which is observation beyond or against, or maybe a controversial issue, which is not the universal guideline. Whereas cholesterol stones can be better managed with no complications or very minimal complications. And my choice of treatment is Arogyavardhini and Kumari Asava in such conditions. The gallbladder wall thickness of more than 8 millimeter is always a sign of possible complications which can occur, and that's one of the important criteria which I would consider. Now, as far as the universal guideline exceptions for the conservative management would be, if the patient's gallbladder is calcified, if there is a hemolytic anemia and hence the patient has a high risk of pigmentary stone formation, and in the universal guideline, a large gallstone of greater than 3 cm is considered as a high risk. Of course, 3 cm is a rare event. Usually what we get is around 1 to 1.5 cm in cholesterol stones, and that can be managed medically. But as per the universal guideline, a large gallstone of 3 cm is also a high risk for gallbladder cancer. And morbidity like obesity, patients who have undergone bariatric surgery, and genetic like Native Americans planning to have a transplant, like if the patient has some immunosuppressive therapy and so on. These are the indications for the surgery as such. And as far as the history of gallstone, this cholecystectomy is concerned, the choice of the treatment was cholecystostomy. In 1882, Johann August Langenbeck, he did a cholecystectomy accidentally. It was not done earlier. The first of the cholecystectomy done was an accidental removal of gallbladder. Earlier, gallbladder was considered to be a vital organ, and removal was considered to be possibly a high risk condition. But in 1882, he did one of that, and then he did a series of that cholecystectomies and presented a paper, and that became a universally accepted phenomenon, because cholecystectomy would be reducing the chance of recurrence. Cholecystostomies, where the stones were removed and the gallbladder was retained, had resulted in a high risk of the gallstones as such. Now, in the in 1985, laparoscopic cholecystectomy was practiced as such. In the present day situation, more than 12 million cholecystectomies are done annually, and majority of these surgeries now done are either laparoscopic or the open surgeries. Open surgeries are now becoming reduced remarkably. Laparoscopic surgeries have increased very remarkably, and this is about the global incidence cholecystectomies per 1000 population, and among them laparoscopic surgery has become now more popular because of the lesser incidence as such. With this we will conclude today. We will continue in the next session about the biliary obstruction and its complications and causes as such. If there are any questions, we will try to answer. There are some questions like how to measure the values of bile salt and phospholipid cholesterol in the local bile secretion, total bile secretion. See, that would be possible when you have a T-tube inserted, or the bile also could be collected by a needle and aspiration from the liver. So usually this is done only in those patients where there is an obstructive jaundice, or the patients who are under a T-tube, not the routine things like routinely we do not do the analysis of the bile. Our bile could also be collected by a Riles tube insertion, but not very common. Then another of the question is use of the USG finding during snehapana of thickness type of stone. With the stone patient, one go for omanotherapy or not. As far as the stones and Vamana, I think it is not a contraindication if the patient is asymptomatic. But if the patient is symptomatic and if the patient has a cholecystitis, I think it is better to avoid Vamana. Asymptomatic patients, definitely Vamana can be given. Then use of the UST finding during snehapana of thickness type stones, I think, see that thickness of the gallbladder wall doesn't change in a day or two. It cannot just reduce or increase. It's suggestive of a chronic inflammation. So I do not expect a change to occur during the snehapana, though I don't have any direct experience of studying that kind of issue. But theoretically, it may not be. It's not expected that the gallbladder wall can be changed. The thickness of the gallbladder can be changed. Then in Vamana, how expect Pittahara? So even after the cholecystectomy, the bile would be secreted, but only the difference is the bile would be less concentrated. it's not that the patients after cholecystectomy would not have the bile. So bile would be present, and rather the quantity of the bile in the gastrointestinal tract after cholecystectomy is more. So in Vamana to expect the Pittanta is not a major issue. It's quite possible. Maybe that even the biliary appearance in the stomach could be more after cholecystectomy. Very often after the cholecystectomy, patients may have a higher bile contents, biliary reflux would be more, and hence the pH of the gastric juice could be lesser in patients who have undergone cholecystectomy. So that's the issue, right? Any more questions? No. Right. We will wind up today. Continue next session.